So today we're going to be talking about metalwork, and I'm delighted to welcome Mr. Ash Vasireddy from King's, who is a trauma surgeon who basically can do any joint, any limb, anything, as long as it's trauma. He is going to tell us all about the types of prosthesis that we use. So thank you very much, Ash. I'm looking forward to it.
All right, thanks very much. I'll just start sharing the screen. All right, welcome guys. Well, I'd like to thank Elizabeth and Heba and Dimitri, who's going to be joining us shortly, for inviting me to talk today, and then for my counterpart Marcella, who's a consultant at King's as well, for inviting me to talk here at this webinar. So what I've been asked to talk about is the types of prosthesis and metalwork. So please interrupt me or put questions in the chat box if there's anything that you want to ask while we go through this. It's just easier to cover it that way. So as Elizabeth said, I'm an orthopedic trauma surgeon at King's College Hospital. So I only do broken bones. I don't do any of this elective stuff that much anymore. I'm also a pre-hospital care consultant in the regional ambulance service, and then have some academic appointments as well. There's no conflict of interest with this talk, but the organizations I'm relevant and work for are at the top. So starting with what we're going to achieve today, hopefully learning objectives wise, just to understand some typical biomaterials that are used in orthopedics, and then we'll just talk specifically about screws, plates, intramedullary nails, and then arthroplasty instruments, which are probably the main one that we'll then concentrate on later in this webinar. So biomaterials. Okay, so they're essential to orthopedic surgery. Without biomaterials, orthopedic surgery is pretty much wound washout, tendon repair, and not really much else. There's a huge amount of metal alloys that we tend to use or can use, and we also have ceramics and polymers. Now, the metal alloys that frequently we do use in orthopedics are basically threefold. So it's stainless steel, titanium, and cobalt chrome. Now, what's an alloy? Obviously, an alloy, as you all know, is just a mixture of different metals. Now, in stainless steel, the main one is iron, but obviously there's chromium, and then there's a load of others. And in orthopedics, the alloy that we specifically use is 316L. You don't really need to know about that. Most orthopods barely know about it. I wouldn't worry. But it's just that specific type of stainless steel. Then there's titanium, which again has other metals in it to give it its properties, and cobalt chrome. So 3 types of metal alloys. So stainless steel, why do we use stainless steel? Right. So stainless steel is used in a variety of implants. So there's some trauma implants you can see here, some DHS type stuff, some plates, and then some hemiarthroplasties. So used in a wide variety. It's strong, very strong. Ductile, so you can manipulate it and you can bend plates, you can bend screws, etc. And these are all properties that you want to use during your orthopedic surgery for different reasons. And we can talk about that later if you want. It's also resistant to corrosion. Clearly, the last thing you want to do is put a metal alloy inside someone and then for it to corrode away and wear away over time. So you want something that's resistant to corrosion. You want it to be biocompatible, i.e. you do not want it to elicit an immune reaction. And you want it to be cheap. And then that way, everyone's kind of vaguely happy about it. And then if you're like me, you can put tons of it in and no one really blinks. In terms of titanium, so this is titanium, again, really good properties. It's resistant to corrosion. It has a really fine oxide layer on the top, actually, which makes it one of the most biocompatible materials there is. Again, it's ductile, so you can manipulate and bend it, etc. Fatigue resistance, so it's very good at taking up strain and not kind of breaking. So if you could imagine taking a spoon in your hand, and if you keep like gently trying to bend it, you know, over the course of like 5-10 minutes, it'll gradually bend and eventually it may fail and break. And that's what tends to happen to implants over time. But titanium is very good at resisting that. It's in terms of its strength properties and fatigue properties, it's very similar to bone. And it prevents a phenomenon called stress shielding. Just so you know what stress shielding is, if you put an implant in someone, say a hip implant, for instance, or a knee implant, or you put some plates and screws, etc., the bone next to the implant, the bone immediately next to the implant loses some of its strength, because obviously all that strain the bone has been taking over the years that it's been there has led to it becoming very strong, having lots of calcium, etc. But by having an implant take that load, the bone effectively weakens because it thinks it doesn't have to do the work. So just like, you know, if I cycle to work every day, my leg muscles will get really, you know, bigger maybe and get stronger and fitter. But then if I just start driving everywhere, they'll just fatigue away. Same thing happens to bone. So bone next to an implant usually undergoes something called stress shielding, and it becomes less strong. Now, it's difficult to see that sometimes because, or you may artificially interpret that sometimes, because if you look at a radiograph, and we'll see some later, you can see like a very fine halo behind an acetabular cup in a total hip replacement. And that really is more of a MAG effect, which I hopefully the radiologist will talk about more than me, rather than stress shielding, but just something to remember. Cobalt chrome, okay, another common one. Resistant to corrosion, biocompatible, but the strongest of all the alloys, super strong. So ceramics, yeah, so we use ceramics a lot, and ceramics are really only used in arthroplasty. There's no trauma operation that needs sand, but there is lots of arthroplasty operations that need ceramics. So they're metallic elements bonded with non-metallic elements. Okay, so yeah, they're either derived from aluminium, zirconium, silicon, etc. And they're made by basically mixing a ton of powders together with water, really squeezing the powder and the water really tightly together, then you get a cast. And the cast is basically like you effectively get a rod of ceramic stuff. And then you heat that to a high temperature, and then kind of from that you manufacture what you need. Be that a femoral head component, as you can see here, that's colored pink, or a acetabular liner that's colored pink here. Now it's granular, it's basically, it's ceramic. It's like the same kind of ceramics that you would see, you know, in China, in Chinaware and stuff that you have at home. But obviously it's in properties are slightly different, but it's derived from the same thing. So it is very granular and grainy if it was to break. It's very hard, it's very stiff, but it's brittle. Limited uses, as I mentioned, but mainly hip arthroplasty. So the other thing that we use are polymers. So polymers. So the two commonest ones that you'll see in orthopedic surgery are bone cement and polyethylene. Okay? So in bone cement, it's PMMA, so that's polymethyl methacrylate, but don't really worry about that. It's derived from dental cement, but obviously the technology has improved over time. And so what we have now is quite an advanced version. It comes as two items. It typically comes as a powder and a liquid. And you make your cement by mixing the two together. This causes a polymerization reaction. It's exothermic, so the cement becomes very, very hot. A lot of cements these days also contain antibiotics, and they're used to help fix implants in place. So think of them as the grout that you put when you're tiling something. It's not a glue, it's a grout, so it fills the space. It does not stick anything to each other. It becomes sticky, yes, but it's effectively filling a void. So then we have the other polymers, as I mentioned, polyethylene. Again, this is formed by taking granular powder here on the top left of the image, fusing it together at a low temperature and pressure, and then you get your casts, your rod of polyethylene. And then you just take it to manufacturing, and then the company effectively cuts out what it wants from it. And then you get these polyethylene shells, liners, etc., that we use in total hip replacements, or the spacers that we use in knee replacements, or liners that we use in shoulders, etc. So this is how polyethylene is made. There are other things that we do to it to make it strong and keep it strong and keep it sterile, and that can affect its property, but the principle is you have granular powder, low temperature, low pressure, you get a cast, and then you basically cut what you want out of it. It's very strong, it's resistance to wear, and there's obviously an ongoing evolution in developing all of these components, including polyethylene. So we'll talk about screws. Okay, so I just put a ton of pictures here because like I think put words about screws has become slightly difficult. So we use lots of screws in orthopedic surgery. The key principles just to probably remember is that under X-ray, they all look vaguely similar. It's very, very difficult to tell, but they all come in a huge variety of sizes. So you got some that are, 2 millimeters wide, 1.5 millimeters wide, all the way to things that are nearly a centimeter wide, etc. The screws usually are either inserted independently, so they're put in on their own, and they're usually used to fix two broken bones together and squash them pieces together, or they're used with plates. And if you look at the image here on the left, and the two things to remember for screws here in this case are what we call a locking screw and a non-locking screw. So your normal screw that you would have at home if you're putting up a shelf would be something called a non-locking screw. So that's in this picture on the left, it's the screw on the far left or the far right. So this sits on top of a plate typically and basically squashes the plate onto a bone and holds it in place. A locking screw, on the other hand, has tiny threads cut into the head of the screw that allow the screw head to be locked into the plate itself, making it a much stronger construct. And we use this to our advantage when fixing bones, etc., and do it in order to do it a certain way to maintain an appropriate level of stability for fracture fixation. In terms of screws themselves, as I mentioned, different sizes. The threads of the screw also can take up different lengths within the actual screw, the overall screw length. So again, very variable. You have some cannulated screws that work in a Seldinger fashion, as in you put a guide wire over it, and put a guide wire in to the bone first, and then you put a screw over that guide wire. And then, as I mentioned, you can use these independently, just in bone on its own, and you may start seeing that a lot if you work in a major trauma center doing pelvic surgery. You'll see a lot of independent screws, or we use them with a plate. In elective surgery, in arthroplasty, for instance, you do use screws as well. We can come into that. And they're used typically, again, for fixing implants into position. Screws themselves usually are stainless steel based or titanium. There's not many cobalt chrome ones around, stainless steel or titanium. Okay, so plates. So plates, again, ton of different types of plates. Okay, there's no point necessarily going through all of them. The two basic principles to remember for plates are, you can either get straight plates of varying sizes, like you see on the far left here, or you can get anatomically pre-contoured plates, like you see on the right two pictures. And those plates are typically manufactured and designed to fit on certain parts of the body. So you'll get one that's designed to fit and sit on the proximal humerus, one that's designed to sit on the anterolateral part of the tibia for a tibial plateau, ones that are designed to sit on the back of the distal humerus. So they're all designed to go where they're meant to go, or you use straight plates. Again, plates generally stainless steel and titanium. There's not really any variation. What we do try and do is make sure we're using the same metal for the plates and screws. So we would never really mix a titanium plate or a titanium screw with a stainless steel implant. So we'd never mix the implants together, because if you do mix stainless steel and titanium together, there is a risk of getting corrosion at the junction where the two implants meet. So we always stick to the same implant throughout once we decided which one we're using. And generally, most people will use stainless steel for generally fracture surgery, and that's what most of the implants have these days. Intramedullary nails, just in case, just recapping kind of how we do this operation as a whole. So intramedullary nails, you have a broken bone, obviously, you could see that. And it's a percutaneous operation. Sometimes it needs large incisions, but it's fairly simple. Again, if you think about it like a Seldinger technique, we're making a hole in the top of a bone, putting a guide wire down it, cleaning out the canal, and then dropping an intramedullary nail down the canal of your long bone. And we have to put these interlocking screws in the top and the bottom, also known as interlocking bolts. And this helps provide some rotational stability to the fracture. If we weren't to do that, what tends to happen is the fracture still tilts around or rotates around its fracture point. Intramedullary nails, again, titanium or stainless steel, doesn't really matter which. So hip replacement surgery. So how do we do this? Again, it's fairly straightforward. Once we do the approach and get to the hip joint itself, what we have to do is cut off the head and the neck. The next thing we then do is core out the acetabulum, so remove all of the cartilage from the acetabulum. We then prepare the top of the femur by sending a special instrument down to clean out and effectively curette out all of the cancellous bones. So we have a nice cortical shell, and then we then send the femoral prosthesis down into the femur. We put your acetabular component into the acetabulum, and that's it. And hey presto, there's a hip replacement. And so we'll talk about this later, but there's obviously huge amounts of variance in the kind of implants that are used for this. So a couple of things for hip implants. You obviously need a femoral stem, so something that goes inside. Now, if you just focus on the picture on the right, if you look at there, there's 4 stems. There's a very polished one you can see on the left here. And then as you go across to your right, these stems become slightly different in shape and have different coatings. And effectively, when you put your femoral stem down, the stem either has to sit inside the canal and contact bone, or, and that's an uncemented implant, or it can be a cemented implant where you put the implant down with cement already inside, and that helps hold it in. You can do the same thing with the acetabulum. You either put a cemented acetabulum component in or an uncemented component in. Which one you choose is really up to the surgeon, and there's some variance as well between different hospitals and their standard practice. And typically for the acetabulum component, you can either put a plastic liner on its own in with cement, or what most people these days are doing is putting a metal shell in, as you can see here, and then either putting a plastic liner or a metal liner or a ceramic liner like so, and then putting an appropriate component for the femoral head. Oops. In terms of the hip implants, as mentioned, you can put the acetabular components on their own in, and these ones here on the top left go in with cement. You can also put components in the one in the picture below, where the socket is made of metal, and then you use screws, which are these 2 little things poking out, to help hold it in place. Sometimes if there's a lot of destruction of the bone and there's a lot of bone defects, you can put in trabecular metal into these bone defects, and they're fixed in with screws as well. But as I said, most of the time, most people are using these metal shells, as you can see here. They're smooth on the inside, they're rough on the outside. The roughness on the outside allows bone to grow into them and interdigitate into the metal shell and help hold it in, giving it a longer longevity within the patient. And then you then put your liner in, and that can be ceramic, metal itself, or plastic, and that locks into that shell. And sometimes they have these little holes in which you can put screws in to help hold the shell in place. Okay, hopefully all of that was making sense. Total knee replacements, again, these can be uncemented or cemented, but on the whole, these are generally cemented. You have a femoral component made out of metal, a polyethylene spacer, and the tibial base plate that's made out of metal. And they effectively go in, as I say, usually with cement, plastic spacer in the middle, and that's it. In terms of more complex implants, you can have bigger implants that again have this tibial base plate, but then have longer stems that go down the length of the tibia or up the length of the femur. And also you can have unicompartmental knee replacements, so half knee replacements where you just do half a knee replacement, typically on the medial side of the knee. You can do ankle replacement surgery, and again, you can be cemented or uncemented, metal implants on the side of the bone with a plastic spacer. So hopefully you've got the gist of it. It's cemented or uncemented. You've got a metal implant that's a bit that goes into the bone on either side, and there's something plastic in the middle. Okay, fairly simple. In terms of upper limb stuff, the elbow, you can make this complicated if you want to, but again, cemented or uncemented, metal implants go into the humerus, into the ulna, and then you have a linked implant in the middle. And that helps you effectively give you a nice hinge joint. You can replace the radial head as well with a stem that goes down the radius and a metal radial head. Shoulder replacements, similar kind of thing. Metal bit goes into the bone, and then you usually have something plastic. So in this case, the glenoid, if you're doing a total shoulder replacement, will be made of plastic. It may have a metal base plate underneath it, but usually it's just plastic. And then you have a humeral component that goes down the length of the humerus with a rounded humeral head made out of metal. Sometimes you can do something called resurfacing, where you effectively just ream away the top of the humeral head and replace it with this metal shell and leave everything else alone. And sometimes you end up with this funny thing called a reverse shoulder replacement, where you put a metal peg down the top of the humerus and then put a metal component on the humerus side that actually makes it the glenoid. So you put a cup on the humerus side, and then you put a ball on the glenoid side. It just reverses the geometry of this. And it's certain things we do for very advanced osteoarthritis of the shoulder, or more typically, people who have a rotator cuff dysfunction, either due to severe injury, trauma, or arthritis. All right, so just in summary, so we've covered a few things about biomaterials. So remember, it can be anything. So there's metal, ceramics, and polymers, which are polymethyl methacrylate cement and polyethylene. We've talked about screws, of which there's a variety, typically stainless steel or titanium. Talked about plates, intramedullary nails, and a wide variety of arthroplasty instruments. So I will stop there. And if there's any questions,
I actually think that's possibly the best teaching session I've ever experienced. That was incredible. And I can just hear the concentration from everyone. Thank you. Okay, so I'm just looking for questions here. We had a question on day one regarding tips for identifying hip hemiarthroplasty. Yeah.
Okay, so the question is, what do you want to identify? So yes, everyone gets their check X-ray or after their hip implant. What do we want to know? Okay, so first of all, we want to know that the implant is sitting where it's meant to sit. And in a hemiarthroplasty, you want to check that the peg is down the femur. You want to check on the AP and the lateral that's ideally down the midline of the femur. Ideally, I keep saying ideally because even I have issues with this, but you don't really want the metal to be kind of abutting the bone properly. You want a nice cement mantle all the way around on the lateral and the AP. But because most of the time we are doing cemented hemis. If we're not, then that's fine. But you want a nice zone of cement all the way around that's even. You want to check that there's no periprosthetic fracture, and that's probably the biggest thing that we just want to know. Usually you kind of know intraoperatively if something like that's happened and you can fix it intraoperatively, but we definitely want to know about it postoperatively. And the other thing is obviously any gross issues like dislocation and stuff, but I would say it's general overall position down the middle, AP and lateral view with a good cement mantle and no iatrogenic fracture that we've missed.
Okay. Great, thank you. Someone else has asked a question. Earlier today, we saw a case where the ceramic liner of a total hip replacement broke down and littered fragments around the hip. If we're concerned, is there any way we can identify if the total hip replacement has a ceramic liner radiologically?
So the next speaker, Marcella's got a great case of this. I won't spoil it too much.
Okay.
But overall, the issue is that, we've talked about a number of different implants, right? So metals all look the same under X-ray, right? It doesn't matter to me or to you guys whether it's cobalt, chrome, titanium, or stainless steel. They all look the same under an X-ray. So that's one thing. Polyethylene looks the same under an X-ray, no matter which manufacturer, which generation, or which type of polyethylene you have. And bone cement also looks vaguely the same. The issue with ceramic is that it's typically used in hip arthroplasty. It's used in the socket and occasionally in the head. The problem you have is when you use a socket that's got ceramic in, the problem is you can't put the ceramic straight into the socket itself. You need a metal back shell. Now that metal black shell will cast a nice white shadow on your radiograph. So you won't be able to necessarily tell what kind of liner is inside that shell, because it could be ceramic, it could be plastic, it could be metal, it could be any of the three. Unless the person requesting the radiograph has written it down, it's very difficult for you to know. You could look at some old radiographs, maybe there was some, where there's a little bit of rotational alignment and the X-ray was taken, that could give it away. but effectively ceramic gives you a kind of appearance. If you were to look at it, it gives you somewhere between cement and polyethylene. It's a very graded opaqueness to it. It's not dense as metal, but it's not quite as see-through as polyethylene. It's somewhere close to cement, probably. Your giveaway, I guess, is if they used a ceramic femoral head, because then what you'd see is you'd see really sharp whiteness of the femoral stem, and then you'd see this fairly kind of hazy whiteness that's not quite as crisp on the femoral head, and then you could probably suspect that's what it's going to be, because your only options for the femoral head in a hip replacement are either metal or ceramic. There's no like polyethylene head that ever goes on. They're typically always metal or occasionally ceramic. So if it doesn't look like a metal head, it's probably ceramic.
So got another question here. What are the common things missed on post-arthroplasty radiographs by radiologists that are picked up by orthopedic surgeons?
So I wouldn't say that there's a huge amount of missed, because you guys are looking for the same things that we're looking at, as we just discussed, you know, fractures, a good cement mantle, etc. I think what you guys don't necessarily comment on, I guess, as much is alignment. You know, when it's so, you know, if you had a femoral stem that went in and it was touching the lateral cortex, and effectively the femur would then be in varus. If it's really obvious, then clearly, in your report, you'd probably include it. But if it was very mild, you wouldn't. I guess you probably may not include it. But then that's really no big deal. That's fine. So I don't think there's anything really you're missing. I think all of you guys generally have got all this all covered. But Marcella covers this very well in her talk. She's got a lot of stuff about this.
Brilliant. And can I one last question before we move on to Marcella? When you were training, what websites did you use when you kind of wanted to look up and see what something was, what metalwork was, you know, what particular metalwork you was looking at?
I don't know if I really did, but I used Radiopedia a lot. But that was about it. But I think, as I say, a lot of the stuff looks the same metal-wise. You wouldn't be able to separate metal out on radiographs, but you would definitely be able to separate metal, plastic, and ceramic out, provided you got the right alignment to take the radiograph. Okay,
great, thank you. I just wondered if there was some secret website that you were all on that we weren't on.
No, it's just I use the Force a lot.
Okay, brilliant. Ash, thank you so much. Like I say, possibly one of the best lectures I've ever heard, and I've heard a lot of lectures.
Possibly.
Okay, so that brings us on now to Marcella. And Marcella is going to be talking to us about elective metalwork complications. Perfect, Sieg. Thank you, Marcella.
Thank you, Elizabeth. And thank you, Ash, for joining and sharing your expertise with us. As I mentioned before, I was hassling Ash all this last month to get some insight in metalwork. He has been very patient and teaching me a lot, so I hope to share some of this insight with you guys. So we're going to talk about metalwork complications today, and just bear in mind that many of these complications it's gonna be touched in a specific lecture when we go through all the joints. So this is just to give you some background and introduction for the complications. Okay, let me see. Okay, perfect. So I'm just gonna keep this for the sake of time, and I'm just gonna start with my slides with the complication we're gonna go through today. And I hope that at the end of the lecture, you get familiar with them and you feel more confident with reporting metalwork complications. So the first thing I wanted to show you is the checklist that I want to propose for checking your x-rays. When you have an x-ray for metalwork, what are the things you have to take into account? So the first thing you can do is just check previous radiograph. It's the key to compare with the previous and make sure that the alignment hasn't changed, that there is no progressive loosening. So that's the first thing you need to look at. Then secondly, identify the type of prosthesis and the components. Ash already went through all of them, so it's important if you can just assess if it's a metallic, ceramic, or polyethylene, because there are some complications that might be more related with this type of components. Then I will check the alignments and the angles. The good news is that the orthopedics are not expecting us to put that in our reports, but it would be good to know what they are, because then you can assess and interpret better the images, and probably more chances they look at our reports if they are more thorough. Then I want to check for the complications that we're going to go through in a moment. Don't forget to look at the soft tissues. It's very important that you look for gas in case there is an infection, fat planes in case there is joint effusions, and the rest of the film, because some of the metalwork can break, and you can see displacement into the soft tissue, and we're gonna see a case of that. And finally, suggest for the imaging, sometimes the stem might not have been imaged completely, so feel free to suggest other projection to include the whole stem in order to put a word on the state of that. CT can be helpful for loosening, non-union, bone scan and white cell SPECT CT for infection, and MRI for pseudotumors. So let's apply this checklist with this normal total hip replacement. So what are the things that we want to look at? The first thing I want to check identify the type of material, and this looks like a metallic acetabular cup and a metallic femoral component. Then I want to check the alignment of the femoral component, that it has to be aligned with the axis of the femur. If you see that the tip of the femoral stem is pointed toward the lateral aspect of the femur, that means that it's in varus position, and that can be a sign we can predispose for loosening. Then check for the interface of the bone with the metal for areas of loosening. Check the gluteal planes for joint effusion. And there are some angles that are important that you are familiar with, which is the acetabular inclination, that should be between 30 and 50 degrees, and the acetabular anteversion, which is checked in the lateral projection, and it should be between 0 and 30. A couple of words about a normal total hip replacement. Just remember that the tibial plateau component should be parallel to the floor, and the tibial stem should be pointing down along the axis of the tibia. And again, if you see that that stem is pointed towards the lateral cortex, that means that is in varus, and that is a sign of malposition. And don't forget to check this transparent area, which is the polyethylene spacers. It should be even, and the interfaces with the bone and the prosthesis to check for any loosening. Perfect. So let's go now to the cases. And if you can log in the polyv.com Elizabeth Dick 087 for your participation, that would be great, because this is an interactive session. So I'll give you a couple of minutes to do that. And let's start with the first case. I hope you all have it now. So the first patient was a lady that had bilateral total hip replacements, and she was complaining of left hip pain. And I wanted to have a look to the x-ray and point out the abnormality. Hope it worked. Oh, excellent. I'm getting answers now. Only one response so far. Yeah. Excellent. 3 answers so far. Okay, for the sake of time, I'm gonna move. Okay, good. Okay. Actually, this case had more than one complication, and I'm glad that people is pointed at it. So what do we have here? So this is a polyethylene acetabular cup, as Ash mentioned before. You can see that is radiolucent and it's cemented. And there is a metallic femoral component. So what things can we assess here? The first thing I want to check is the alignment. Actually, these femoral components in varus position, you see that it's not aligned with the femoral stem, the femoral axis. Additionally, oh, sorry. You can see that the acetabular component shows some lucency around that indicates loosening of the acetabular component. But there is also an extensive area of loosening around the femoral component with anterior displacement and lateral displacement of the femoral stem, and there is fracture of the cement. You can, oh, sorry, I'm just having some echo. So you can assess and mention in your report, something that you can mention in your report is the area of involvement. There are some sums that has been described, Charlie and Gruen Sand, that you can use to include in your report, and you could put the areas of loosening. Sorry, something else I wanted to
Marcella,
highlight.
could you go back just for a second, please, and show us the checklist for the hip replacement?
Yeah. The checklist, you mean like this slide?
Yes, that one. No, sorry, I think they meant the one after that. Come back. That one, yeah, thanks.
Yeah, do you want me to explain again this one?
And someone just asked if they could have a quick look at it again, so we'll just take a moment to...
Okay, sorry.
Yeah, that's okay. I guess they want to see what a normal is like, actually.
Sure, if I'm talking too fast, just let me know.
No, that's all good. Okay, thank you.
That's fine. So yeah, as you noted, well, I don't know if should I describe again the findings. The varus position of the femoral stem, the loosening of the femoral component, and also loosening of the acetabular component. Just a couple of things to show you in the acetabular component. When it's made of polyethylene, you see this radiodense or metallic ring, which because you cannot see the prosthesis, this will help you to assess the inclination of the acetabulum. So this is just a radiographic marker. And this little dot that you see here at the bottom of the femoral component is just the normal cement plug. So in order not to the cement to go all the way down into the femur. So these are normal findings you can see. Okay, so this was a case of aseptic loosening, which is the most common complication. And sometimes it can be difficult to differentiate between septic and aseptic. That's why the clinical information here is very important. There are some criteria, which are loosening more than 2 millimeters, which appears new or progressive in serious radiograph. When you have migration or subsidence of any of the prosthetic components, this means that you can see dislocation, or you can see displacement in the inferior plane to the prosthesis, and it's actually applied for the femoral component. You can see fracture of the metal or the cement that we saw in the last case. You can see periostal reaction or cement lucency or irregularity of the cement interface. As I mentioned, it's difficult to differentiate with aseptic loosening, but some key findings are extensive bone destruction, air in the soft tissues, or extensive aggressive periostal reaction. And in this case, we can see there is extensive periostal reaction, the bone is sclerotic, and you see all these areas of wide loosening. So this was a case of confirmed infection. So I hand over to Ash, who's going to explain the diagnosis and the treatment.
So the issue about loosening is that you always need to actively exclude infection. So if you have an obvious place like the radiographs to the humerus that Marcella had just before, then you can tell that, you know, the bone is very unhealthy. It just looks very aggressive, lots of very aggressive changes in the bone. And you can probably just go on the radiographs themselves. You can kind of be more confident about saying that, yeah, you know, that is probably aseptic loosening. And that obviously in the context of a fracture. So it's an infected non-union or infected hypertrophic union, whatever. However, in joint replacement, it's not always so obvious. It's not always so easy, but have to exclude it. So we always go on the clinical history. So, you know, obviously if the patient's got a fever, an oozing wound, that's bound or obvious. But sometimes you have to ask them when they had their operation initially, did they have an oozy wound for a couple of weeks? Did it take a while for that wound to heal? Do they have ongoing pain that was there from the start of the post-op recovery period, or is this a new pain they're having now? And obviously check the blood tests, and, you know, we'll look at, I mean, some of the most important ones, we look at ESR, we look for trends in that. And obviously obtaining fluid for culture where we can, but this would ordinarily be something we do in theatres. We would never do a bedside, outpatient-based or a ward-based aspiration of any joint replacement component itself. We'd try and do that in theatres in a clean environment. And then obviously then the radiological examinations themselves, which you guys know more about than I. So yeah, so always look out for it. And in this case, they went on to revise it. I mean, we could talk more about it later, but generally, if you have an infected loosening, so effectively septic loosening, the question you need to identify, or kind of the surgeon needs to decide, is, do they need an operation? And the answer is probably yes. So the next thing is, what are you going to do about it? There's 3 ways to treat this. First, open the whole thing up, as in take the patient to theatre, open up the joint replacement, and basically clean the living crap out of it with whatever stuff you have, and wash it all thoroughly and debride all the mucky tissues that you have, etc., etc. Now, to do that and for it to be successful, you need to have identified a causative organism preoperatively that is amenable to antibiotic treatment. So what you don't want is a resistant organism or a very kind of unusual organism. You want a fairly simple Staph aureus that is pen sensitive or something like that. And also you need your patient to be a good host, as we describe it, i.e. not got diabetes, not got any other systemic conditions, be fairly fit, healthy, not on any dodgy medications like immunosuppressants, etc. So you want a good host, a known organism, and then you can basically clean it and then pretend nothing happened, and that's usually okay. The other option you can do then, if you don't want to do that, and you would only do that if someone had a very acute, you could go in, and if, however, you had something that's been ongoing for a while, you can either do one of two things. You can do a single stage revision or a two-stage revision. So in a single stage revision, you take them to theatre, you open everything up, but you take everything out, you clean it all up, and then you put in new implants. But again, to do that safely, you need a good host, and you need to know the bug, and you need to know that the bug is easily manageable and treatable with antibiotics. So lots of liaison with microbiologists.
Thank you, Ash. So it's a companion case of a total knee replacement. And I'm sure you can see the area of loosening around the tibial component. And I wonder if you see any other abnormalities you would put in your report. So I have this question for you, if you can describe the other abnormalities.
Marcella, on your screen. Oh yeah, great, thank you.
Okay, it's coming in a weird shape. Space loss, spacer, okay, excellent. Sorry, it's coming a little bit weird. Femoral spacer lucency. Component deformity, okay, well done. Varus deformity, well done, excellent. Anything else? Effusion, yes. Okay, so I'm gonna move to the answer now. So I hope you pick up the findings, which is great. So it's a varus position of the tibial stem, and you see that alignment of the tibial plateau component is not aligned with the floor. Apart from the area of loosening, some people pointed out that there's polyethylene wear. It's basically bone on bone, so there is no space for the polyethylene, and you can see the abnormal wearing because of the osteoarthritis and because of the loosening. But there's something else in this case, and it's a soft tissue mass. And I remind you to look at the soft tissue, because in this case, they were suspecting loosening or a pseudotumor, and the ultrasound showed a complex collection with debris in the popliteal fossa that appears to be a pseudotumor. Okay, let's move to the second case, which is the same patient of number 1, but he presented now with pain in the right hip. Have a look to the X-ray and let me know your thoughts about which complication are we facing now. How would you describe this X-ray? Okay, so I'm gonna move to poly B. Okay, where? Excellent. Lucency around cement, yeah. Acetabular erosion. Acetabular migration. Okay, so actually in this case, well, all the things that you just mentioned, I'm gonna start with this is a polyethylene acetabular component. And we can see that the cement bone interface is very regular, and you have to be suspicious of acetabular loosening. And as someone said, there is wear of the polyethylene, because you can see that the distance between the superior aspect of the acetabular cam and the inferior aspect is asymmetrical. And there is actually a migration of the femoral heads between that were polyethylene acetabular cap. So this is a case of eccentrical wear plus loosening of the acetabular component. And as I mentioned, the key is always to look at the previous radiograph, and you can see that actually the acetabular inclination also has changed secondary to the loosening of the acetabular cap. Case number 3 was a patient that was involved in the road traffic collision, and this is his radiograph. So what would be the most appropriate treatment for this complication? Okay, we have. Okay, so we have split answers. Okay, excellent. Most of you say removal of the metalwork and washout. That's great. So I hand over to Ash, who's going to explain this a little bit.
Thanks. Okay, so I really apologize for getting disconnected earlier. I'm like on my 3rd device right now because I had to give up my laptop. But anyway, so this, yeah, it's a slightly funny story. So if you saw this on its own, you want to know why did that dislocation happen. But in the context of this case, we know a few more details in that, we're obviously thinking about infection, etc., with an oozy wound and all these things. That's fine. So this patient has had the other option that we kind of talked about, which is an excision of all implants and leave alone effectively. It doesn't necessarily mean that you can't go back in. So in this case, what they've done is an excision arthroplasty in that they've taken out all the components. So they've gone in, taken out the cup, all the associated screws, taken out the femoral components as well. And then Marcella's got this black arrow with a question mark pointing at some parts within the acetabulum. And so what we occasionally do, and I mentioned it earlier, that we sometimes leave behind some cement in order to fill the void, so fill the dead space to stop everything, all the tissues contracting. But also these cements contain antibiotics. And then so we put different antibiotics depending on what organism is there, and then we can do some targeted treatment. And these antibiotics leach out slowly over a course of about 6-7 weeks, as in during that whole time, and give some local treatment of the infection. And so the ones that have been used in this case are some prefabricated ones you can buy from a company, but you can kind of make this yourself. It's not particularly difficult. So yeah, so that's where we are with this one.
Yeah.
Back to you, Marcella.
Thank you. And the MRI, just to show you, apart from the collection and the extensive inflammation in the soft tissue, you can see actually the antibiotic beds in the fluid sensitive sequence. So that was a case of infection. So the following case is a lady that had a total knee replacement 1 year ago. And I just wanted to get your opinion on where is the complication, where is the abnormality? If you can point out the abnormality. Or the abnormalities might be.
Can I check, is everyone actually getting that question up on the screen on their mobile?
It's not coming up on Polyview.
Yeah, I
Is it
haven't
not
activated yet, I think.
Oh, sorry for that.
On Poll Everywhere, I mean.
Okay, it's not then. I'm gonna move then to the answer.
Okay.
Because if it's not. So in this case, we checked that the alignment was fine, but actually there was this area of loosening around the tibial component, but also around the femoral component. And you might think, oh, this is no more than 2 millimeters, but the key is to check with the previous images. And you can see there has been a new area of loosening, and there is kind of this periosteal or marginal osteophytes that can be reactive to the motion in the area. And if you see also in the sagittal, sorry, in the lateral projections, you can see that before the metal bone interface was completely fine, but then you see this new area of loosening. And in this case, the patient got a bone scan, which is something that you can suggest to exclude infection, and the orthopedic surgeon sometimes will request one of these ones. And actually, what you look at is this 3 phases bone scan. The first phase is a vascular phase that looks for hyperemia. And in this case, there was some vascular activity already in the bone scan. The blood pool phase is when the the tracer goes into the soft tissues. And again, we can see activity in the soft tissues in this blood pool phase. And in the late phase, we could see some uptake of the tracer around the prosthesis. So this was a case of infection, but just bear in mind that sometimes inflammatory changes can appear in the similar way, and you might need a SPECT CT, which is the one that is gonna give you the answer. So in this case, the Metalwork was removed. And Ash, you want to add a couple of words about what is this?
Yeah. So Metalwork removed, and this is what I talked about, two-stage revision. So the first stage is you make your incision, you can see the surgical staples there, it's quite a big incision. And then you take out all the metalwork. You need to debride all the unhealthy tissue in all of the layers. If that means taking edges of the skin away, of the fat, the fascia. We obviously try not to take away any bits of the patella tendon or the extensor mechanism. Don't want to do that because that would compromise function. But then you definitely want to take away any kind of membranous tissue, infected tissue, devitalized tissue from the bone and the synovium. And you know, the dissection itself can just take an hour, hour and a half. It's quite a lengthy process to make sure you do it really well. And then you clean out everything. Once you've taken out the implants, wash it thoroughly. And then you can either make or buy these prefabricated cement spacers that kind of look like a really shoddy knee replacement, but that's the idea. They take up the space. They allow the patient to have some knee movement, so you know the muscle's not completely wasted and doesn't get too stiff. But obviously they can't really put any weight on it. It's not that strong. And then after a period of time, you would then go in. Thank you. You'd then go in, take the metalwork out. Take the cement out and then put your new implants in. In terms of the timing of when you do the second stage of taking cement spacers out and putting the new implants in, it depends on a number of things. It depends on this improving CRP and clinical picture over time. And in this time, the patient's also on IV antibiotics via PICC line or some sort of tunnel line for at least 6 to 8 weeks, occasionally a little bit longer. Can be up to 12 weeks. It really depends what the organism is and how they're recovering from it. And then when you do this, you typically have to put a more complex implant than you had initially put in. So you'll see here on this total knee replacement that, you know, the bit that goes on the femur and the bit goes on the tibia, the plates, the base plate of the tibia and the femoral components, similar shape. But then there's this long metal stem that's going up and down the femur. And then you'll see this metal vertical line in the middle of the joint. So this is a linked prosthesis. So normally in a knee replacement, you just have the femoral component, the metal tibial component, and the spacer in the middle. And in that scenario, then you're relying on the ligaments of the knee, typically the collaterals, to kind of provide some stability. Occasionally the PCL, depending on the type of implant you put in. So you're relying on ligament stability. However, in infected situations, the ligaments usually are defunctioned either through destruction or attenuation. And so the knee's not really stable like it once was. And so you have to put a linked prosthesis in where the knee itself is inherently stable because there's a rod linking the femur to the tibia. And if you did not do that, you'd end up finding that this patient's knee would be truly subluxating at the tibiofemoral joint. So yes, it's a linked prosthesis. Back to you, Marcella.
Thank you, Gash. So actually, this patient presented 5 years later from the revision with a prosthetic fracture, which is one of the other complications we can see in Metalwork. And I wonder if any of you see another abnormality in this prosthesis that can actually be a risk factor for periprosthetic fracture. I'm gonna go through that because of the sake of time, but I hope you can identify that there was a part of the fracture that everyone can see it. There is area of loosening. And this area of loosening can predispose to this fracture. So it's very important that you don't just report the fracture, but any factors that can have an impact in a management. And this patient again got a bone scan that shows an activity around the tip of the femoral component, secondary to the lucency at that area. And these periprosthetic fractures can happen because different reasons. But as I mentioned, you have to be aware if there's any loosening or not. The Vancouver classification, maybe Ash can mention a couple of things briefly.
Yeah, I'll yeah, just I won't bore you to death with it, but basically it just talks about the thing about the Vancouver classification is fairly simple. So it talks about two things. One, where is the fracture? Is a fracture in and around the hip joint itself near the femoral stem, or is a fracture very distal to the femoral stem? Now, if the fracture is very distal to the femoral stem, you can treat that as it's a separate injury and you can fix that in your normal way, be that plates, nail, whatever. However, if the fracture is in and around the femoral stem, the only other question you want to know is the femoral stem loose or not? If the femoral stem is loose, it means that you have to revise it. Because if you were just to fix it, the whole thing would not really heal. The hip would not be stable because you've got a femoral stem rattling around inside a really loose femur. So loose femoral stem, fracture around the femoral component, revise it. If it's stable around the femoral component and you've got a fracture there, then you could just plate that. And then if you've got a fracture to the femoral implant itself altogether, so like a distal third femur fracture, then just treat that as a separate injury and ignore the hip replacement. That's basically it. And then in this situation, they've kind of done what, well, they've had to do what one would ordinarily not want to do, because they obviously had a fracture. The Vancouver classification, by the way, apologies, is just about hip replacements. There's similar ones for the knee, but the principle for the knee is largely the same. So they got a fracture around a femoral component of a knee replacement. One, we know that it's loose. So then I've literally just told you 10 seconds ago that that should be revised. Yeah, so the reason this wasn't revised is just we're running out of implants for this specific scenario. So we have no choice but to just fix it in the traditional manner. So that's why in this case, he's got plates and screws to fix that bone. And you kind of do it in a way and set up your fixation in a way that you're relying on the bone to heal on its own over time. Back to you, Marcella.
Thank you, Ash. So the following complication is, as you can see here, is fracture of the actual metalwork. And in this case, there was a patient with a previous tibial fracture, and they wanted to assess union. And as you see, there is no union of the fracture after some years after the initial injury, but there is fracture of the intramedullary nail in two places and of the screw, and there is a varus deformity of the tibia. In this case, the metalwork was removed because it was, anyway, there was no union and they needed to do something to fix that fracture. So the following case is a patient that presented with this radiograph. And I'm sure everyone can see the normality that the metalwork had actually removed, have been displaced. There is a dislocation of the acetabular polyethylene component. And this was secondary to loosening of that component. In the cases of dislocation, you always have to consider infection. There are other factors secondary to trauma or the surgical approach, but you always need to consider infection in these cases. And this is the treatment. So Ash, back to you.
Thanks very much. So yeah, so this is what we talked about earlier kind of already, excision arthroplasty. So, you know, your options are you could open it, debride it, wash it out and close it, or you can change the implants, etc. But in some situations, especially in people with low functional demands who are a poor host, i.e. lots of medical comorbidities, potentially immunosuppressive conditions, diabetes, etc., then sometimes it's just better to bail out and do an excision arthroplasty. Clearly their function is completely compromised because they can't, surprisingly though, you find a lot of these patients are actually somehow still able to walk, but it's nothing like normal. And so you'd only do it in those low functional demand users. So, as I say, make your incision, you take all the implants out, you clean it all up, debride anything mucky, and then you just close it all up. And what tends to happen is kind of what you see in the radiographs. You get some hematoma in the middle and you get some sort of weird interposition arthroplasty forming where you get scar tissue in the middle that forms some weird pseudoarthrosis and you get some movement. Back to you, Marcella.
Thank Ash. Okay, so the following case was a patient with bilateral hip replacements and painful on the left hip. So if you can point out the normalities, let me know if you see the slides. Hopefully you see it in Poly B. I was having some problems before, but hopefully it's working now.
Yes, it's, oh no, it hasn't come up yet actually.
Oh,
Sorry, Marcella.
oh, no way. Sorry, is it not? Okay.
Well,
What a bit.
it hasn't come up for me. It may have come up for other people. Please let us know on the chat if you're seeing it.
It hasn't come up now.
No, it
No?
hasn't come up.
Oh, sorry for that. Never mind. Okay, so let's go to the case now. So this is a case where, again, this is a polyethylene acetabular component. You can see that acetabular inclination is wrong. If you compare with the other side, which is normal, this one is quite angulated. Additionally, the femoral head is not within the cup, but is dislocated superiorly. And what is this? Well, this is an area of semen extrusion, which you can see quite often, but that's normal. It's not, doesn't have any significance. But if you see semen extrusion coming from the femoral component, it could be related to a fracture when the metalwork was inserted. So this is a nice demonstration of this complication, which is not very significant unless you see it in the femoral component. The following case, again, a patient with bilateral total hip replacement, a sickle cell, and he referred pain on the left hip. I don't know if you can see the Poly B case.
We can't see it on our phones, I'm afraid.
Okay,
Never
sorry
mind.
for that. But okay, so this is the normality in this case. You can see that as someone asked before, that was the ceramic liner that fractured and dislocated into the soft tissue, and the patient could feel a cramp underneath the skin. So the key here is just to look for the soft tissues on your playing field, but also look at this irregularity border here from the ceramic liner that has broken and has fallen to pieces and displaced. This is a very uncommon complication. Sometimes you can see cases like this where you see that the ceramic liner has fragmented, and you can see like, you can misinterpret this as a heterotopic bone formation, but in this case, with this ceramic liner fragmentation. We are almost going to get into the end. The next case is a patient that presented with a posterior hip fracture dislocation, and it was fixed with plates. And he started developing this bone around the hip and the acetabulum, and he was complaining of reduced range of motion. And this actually is heterotopic bone formation that can get mature in between 6 to 2 years. And in this case, in 6 months, we can see the mature bone actually causing ankylosis of the joint, and the patient was unable to abduct. And I see that we see that quite often, but not as gross as in this case. There are some predisposing factors for patients that are producing bone, like ankylosis spondylitis of Dish. And there is this broker classification that just refers to the degree of ankylosis. Grade 4 will be the complete ankylosis. Back to you, Ash.
Thanks very much. So, yeah, heterotopic ossification. So it commonly happens, I guess we see a lot in head injury patients, whether they get operations or not, but typically it's sites of operation. The hip is the kind of the textbook location, really. And typically if you've had to do a posterior approach to the hip, or you've had to deal with acetabular fractures, that's when we do it. There's lots of theories as to why it happens. In terms of how you manage it depending on the patient's symptoms of how much pain they're getting and how much their function is affected. And in terms of whether you do surgery to resect the ossification, ideally you should do it once it's mature. So it's not something you're doing very quickly. So not something you do within 6 months of an operation or even a year. You'd be really giving it a long time to do. And then once so that when you do resect it, you don't just get it forming all over again, because that's the risk if you do it too early. You just get recurrence. And yeah, it is just basically like finding a piece of bone, you chip away at the top and the bottom. It's quite extensive. It's not always that clean and neat surgery to do, but it does improve patients' functional status afterwards. Preventive strategies, Marcella's already put it on the slides, but the biggest ones we tend to do in this country is probably just indomethacin. Radiation is a common one that's in all the books, but the only places I've ever managed to find that do radiation are all American institutes.
I think 1 or 2 potentially in the UK, but like most of us either do nothing or we do indomethacin. Back to you, Marcella.
Thank you. Okay, we're coming on to the last case, and thank you for bearing with us. So this case, I just wanted to know if you learned something from this lecture. And this case was for that, but I'm not sure if you're gonna be able to see my slides and be able to reply if this is normal or abnormal.
Marcella, we can use the chat function to answer, don't worry.
Yeah, we can, okay.
I'll read out the answers. Don't feel shy about typing into the chat function, everybody.
I think it's working.
It's actually
Oh, is
coming
it
up
working?
Yeah.
Oh, great.
Oh, thank you. The last one. Normal, okay. Abnormal. Can I know, can the people that say abnormal, can you put in the chat why, and maybe Elizabeth or Dame can reply, can just read the answer. Why do you think it's abnormal?
So someone said protrusio.
Okay.
Someone points out we actually can't see the whole of the AP. Is there any way that you could
No,
you can't change that? And never mind.
50-50 actually, okay?
Now you know what it's like for us to look at radiographs sometimes, eh?
Okay.
Send them back.
Any other answer?
That's it, I'm
No,
afraid.
Okay, that's fine. So actually it was abnormal, but I'm gonna explain you why. I think it's not an easy case, and the answer is in the previous radiograph. So this is where we are now. And the first thing that caught your attention is the morphology of the acetabular cup is almost rounded. It's like, doesn't look like a half moon, right? And if you check the acetabular interversion, remember that it should be almost flat between 0 to 30 degrees. And if you look at the initial radiograph, which was normal, you can see the progressive loosening around the acetabular component, but also in the lateral projection, the progressive inclination of the acetabulum, and this was a case of marked anteversion, and secondary to loosening of the acetabular component. And this patient got a SPECT CT that demonstrated this activity around the acetabular components, particularly at the tip, secondary to the macrofractures because of the axial loading in that area and at the vertebrofemoral, acetabular cup. So the patient got revision. Maybe Ash, do you want to comment something here?
Yeah, no, so this, I mean, there's not a huge amount to say. I mean, other than this, so, you know, there's a wide variety of different type of implants, and here you can see what looks like this ridiculously massive femoral component that's actually quite long. And they've got a small cable around the femur. Maybe they had an intraoperative fracture as well. That's why that's there. And then you can see the shell on this time. The shell they've used here has got this the screws in to help keep it in position, because obviously they had loosening before, so they probably had a hole there that wasn't quite evenly spaced out, not quite concentric. And so when you put a shell like this in, you do want to make sure it's secured. And here, if you look carefully, you can see the metal shell. You can see the femoral head itself, that's metal, and then you can see effectively like a lucency, and that's your plastic liner that you can tell. And so that's how you tell. But it's lucky that you can see it on here, but generally you can't always see it. And it's very difficult sometimes just on plain radiographs to tell which liner you're dealing with. And on that lateral, the fact that you can see an empty screw hole and effectively lucency through it tells you that clearly it's a plastic liner in there. Because if there's anything else, it would be opaque.
Yeah, so this patient, after the revision, he presented with persistent pain on the hip. And as Ash said, there was no significant abnormality that could explain the symptoms. And this is when they suspect that it could be a pseudotumor, and they might request an MRI. And in this case, they requested the MRI, and we can see the solid synovitis in the right hip joint in this metal-on-metal arthroplasty, and they extend into the iliopsoas bursa. But you see that the signal of that fluid is really dark, and this is secondary to the high content of metal debris. And this is a case of pseudotumor, which is a reaction to the debris that are produced for that metal or metal prosthesis. And it forms like a type of non-neoplastic solid or cystic mass around the arthroplasty. it might be difficult to see it because in radiograph, it can be completely normal as the case we just saw. And in long-standing cases, you can see some loosening, you can see some radiodense joint effusion, but what you're gonna see usually is the periprosthetic soft tissue mass, as in this case that of the total knee replacement where there was a confirmed case of pseudotumor. And MRI would be ideal to see this complication. And sometimes you can measure the serum ion levels as part of the workout. And this is all. We have gone through all the complications of joint arthroplasty. We feel that now you have an idea of what are the things that the orthopedic surgeons are looking at. Always look at the previous radiograph. It's very important when reporting metal work. Use a reporting checklist so you know what things to look at. And don't limit your report just to say position and show. You now have some basic knowledge of metalwork complications and what to work to report. So I hope this session was also helpful for you. You had some suggestions, read it. And please don't forget to fill in your feedback. Thank you.
Fantastic. Thank you, Marcella. And well worth staying on a little bit of time for. So that's such a brilliant summary from both of you. So everyone, don't forget to fill in the feedback. The recording of the session will be uploaded onto the link, and that's basically a link to the YouTube channel. So yeah, okay. So I can already see we've got some great feedback in the chat, which we will look at later. And we look forward to seeing you all again for the next session. Thanks everyone and have a good afternoon.